All right, gang, this lecture is going to be based on Chapter 9 out of Shi and Singh, talk about managed care, some changes in the way health insurance is working, has been working, as well as mergers and acquisitions, particularly among hospitals. So why are we talking about managed care? Well, we want to get back to, or the thing that is driving managed care is cost, right, is expenditures on health. And so back in 1960, we spent very little on health as a nation. So I showed you this slide previously. We were spending a lot, but nothing like what we're spending today. So healthcare really took off. Healthcare expenditures really took off when we created Medicare, which we've been talking about, we've talked about in previous lectures, like I said. And by 1984, we were spending $500 billion a year on healthcare. And again, this is not just direct expenditures on patient care, but all healthcare expenditures. 500 billion or less than 500 billion, right, was enough to cause the federal government to kind of get into a panic, and they passed TEFRA, right, the Tax Equity and Fiscal Responsibility Act of 1982, right, which created or changed inpatient reimbursement for Medicare from cost plus to PPS. So we've talked about this in the prior lecture. So major changes, and then later on also shifted to PPS reimbursement for physician services for Medicare. And because Medicare is such a dominant payer in the U.S. healthcare system, private insurance companies typically follow whatever Medicare is doing. So private insurance companies followed with DRG-based reimbursement, right? PPS, DRG is the diagnosis related groups, that we use to calculate the reimbursement for hospitals for admissions to a hospital, right? But 1984, right? Like, look at that. Not even $500 billion. And where are we today? Well, that number just keeps on going up and up and up. Now, what happened kind of in the late 80s? Well, we had managed care started to appear in the late 80s, and we actually flattened the curve a little bit. So this rise was not quite as fast as it was in kind of the early to mid 90s. Managed care really comes into play. People didn't like managed care, and so a lot of the cost controls that we'll talk about here in a minute, got dialed back. And we have seen a continued growth, explosive growth in healthcare costs in the United States, to where we spent $4.2 trillion last year. So let's talk a little bit about, the economics behind managed care. So imagine you don't have insurance, and you're paying a doctor out of pocket. And let's say that that doctors you can go to a doctor and get a medical visit with your doctor for $100, right? And I'm just making up a number, and we're assuming kind of a sort of a vanilla visit, right? So what I've got here, this little bit of economics. So I've got on the y-axis, I've got the price of a doctor's visit, right? And so we're just assuming a constant price of $100. So I'm drawing this straight line out from the y-axis. So regardless of how many visits you get, you're always going to be able to get one more visit at $100. Okay, so that's our kind of operating assumption. Now, this downward sloping line is our demand for doctor's visits. So the first doctor's visit that we get, let's say it's here, is worth quite a bit to us. It's worth more than $100, but we get to buy it for $100. The second doctor's visit we buy is also worth more than $100 to us. The third doctor's visit that we get is worth $100 to us. Then after that, the value to us for a fourth doctor's visit, let's say here, would be less than $100. So we're not going to get any more doctor's visits based on how our personal demand and how we value doctor's visits. So if doctor's visits are $100 based on our demand curve, we're going to want 3 of them, right? So the demand curve captures the value to us for each doctor's visit. So let's say that first doctor's visit's up here. Maybe that's $150. So that first visit would be worth $150 to us. Let's say the second visit is worth $125 to us, right? And so we'd get 2 visits. The third visit is worth $100 to us. And so we'd get that visit. The fourth visit, right? If we drew a line over from the fourth visit here and over here, it would probably be, let's say, $75, right? And so the fourth visit would be worth $75 to us, but the price is $100. So we say to ourselves, it's not worth it. If it's going to cost $100, I think I only value that fourth visit at $75. So I'm not going to buy that fourth visit, right? So we stop at where the price hits our demand curve. And so we wind up getting 3 doctor's visits at $100 each. And so we pay 3 times 100 or $300, right? So that's without insurance. Now let's imagine we have insurance. And let's imagine that with our insurance, we only have to pay $20 per visit. Let's say we have a copay of $20 per visit. Well, before, we only got 3 visits at $100, right? Because that fourth visit was maybe only worth $75 to us. And so since $75 in value is less than the $100 price, we didn't get the fourth visit. But now we don't have to pay $100, even though the actual cost to the insurance company, so this is important, the actual cost to the insurance company is still $100 per visit. So if we go for 3 visits, the insurance company has to pay out $300. If we go for 4 visits, the company has to pay out $400. If we go for 5 visits, the company has to pay 5 times 100 or $500. And if we go for 6 visits, the company has to pay $600. Now, when the insurance company says, hey, you can go see your doctor and it's only going to cost you $20. Well, the price to us is now $20. The price to the insurance company is still $100. The insurance company is stepping in to pay the doctor for the services that we are now getting. So to us, when we evaluate how many doctor's visits do we want to have, we consider our demand curve. We actually, obviously none of us have this line in our head, but we're doing a mental calculation saying, right, oh, hey, you know what? A fourth visit would be worth, like I said, $75. Well, that's more value to me than the $20 it's going to cost me out of pocket. So I'm going to get that fourth visit. And that fifth visit, let's say, is worth $45, right? And so $45 is more than the $20 that I would have to pay. So I'm going to get that 5th visit. And then that 6th visit is worth $20 to me. And I've got to pay $20. So I'll get that 6th visit because the 6th visit is worth $20 to me. And that's what it costs me to buy it. Again, the insurance company is paying $100 for each of these visits that we go to, right? So the actual cost of the care it winds up being, instead of $300 for 3 visits, we wind up consuming 6 visits at $100 each. We only pay out of pocket $20 per visit, so we pay $120. Right? So we pay $120 for something that costs the insurance company $600. And so the insurance company winds up paying $480 out of their funds. Well, their funds, so here's the funny thing. This feels like, wow, I'm getting a bargain, right? The funny thing is the insurance company doesn't do this. This doesn't come out of their pocket. What they do is they figure, okay, if we charge or if we require a $20 copay, we know that you're going to use the doctor 6 times. You're going to wind up paying $120 out of pocket. We'll be on the hook for $480. So your insurance premium is going to be equal to the $480 per year. Let's assume this is a year, right? because the insurance company is not going to lose money. So not only is the insurance company going to charge you $480, but they're going to charge you a premium on top of that. And we did this exercise in a previous chapter where we said what's the medical loss ratio going to be, right? And so if it's going to be 80%, let's say, you divide 480 by 0.8 and you wind up with the actual premium. So for the insurance company not to lose money, they're going to collect your $20 copayments, and then they're going to charge you a premium of, say, something more than $40 a month, because 40 times 12 would be 480. And as a result, you wind up paying the full 600. It's just that you space it out over time. So is this good? Well, you're definitely consuming more healthcare than you would have when you had to pay $100 a whack, right? And so maybe $100 a whack is too expensive for you. Or maybe if you're faced with a $100 charge, you won't go to see the doctor when you really should go see the doctor. So maybe you value preventive medicine treatments like annual physicals less than $100. But in reality, they should be worth more to you than $100. But you put off those preventive care because you don't perceive it that way. And so you make a mistake of valuing preventive care less than what it is really worth. And so what the insurance company does is it encourages you to use more care, and maybe maybe these additional visits are your preventive medicine care. So they're your mammogram if you're a woman over 40. They're your well woman visit. They are your annual physical, your colonoscopy, other things like that. Now, again, I'm 50-year-old, just went through my first colonoscopy, still reeling from the effects of it. But so probably talk about it more than I should. But you wind up consuming more healthcare, and ultimately you pay for it, right? The insurance company is not going to lose money. They're going to plan the premiums so that they cover whatever they expect you to utilize. And if they're wrong, next year they'll just raise the prices even more. So moral hazard, remember, is the utilization of services. In healthcare, it's the additional utilization of services when you don't feel like you have to bear the full cost. So this is a situation where if you're paying less than the true cost of the services, then you're going to use more of them. Whether this is good or bad kind of depends on whether you're getting something that actually, even though you feel like it's not worth $100, maybe it really is worth $100, right? Getting that screening mammogram. Hopefully you're not screaming when you go to get your mammogram, but your screening mammogram might actually be worth a lot more to you than it might feel like. Right? So, maybe you've seen this TV show, some reruns of it. Whoops, let's back up. ER, it was a really popular medical drama. It was fun. George Clooney here, right? Very young George Clooney was a member of the original cast. This was a popular TV show in the 90s. And, I show this for two reasons. One reason is when patients aren't responsible for the full cost of their care, sometimes they get more of it, and sometimes they get it in high cost places. Getting primary care in an emergency room is an extremely expensive way to get primary care. But as you've read about in your textbook, some poor people who don't have health insurance, this is the only way they can access primary care. So they just roll into the ED with something that they should be able to get done with a primary care physician or primary care nurse practitioner or PA. But because they don't have health insurance and they don't have a relationship with a primary care provider, they go to the ED. And the ED is not allowed to turn anyone away. So they go in and they essentially get free care because the ED, once they send a bill, they'll realize, oh, this person, assuming this person is poor, this person can't afford to pay, so we just write that off, and it becomes what's known as charity care. But this is an inappropriate use of resources, right? The ED is meant for real emergencies. It's meant for when you're about to lose life, limb, or eyesight, is kind of the standard saying in healthcare. So one reason I'm sharing this with you is the ED is a completely inappropriate place to get healthcare. But if you are a poor person without insurance, you might go here. And this is, in a way, an exercise of moral hazard, because you know you're not going to be responsible for the cost. The other reason I show you this image is because ER, the TV show, Chicago Hope, also a medical drama based out of mainly around an emergency room. Of the same time frame. One of the popular themes of these shows was patients would come in, need some sort of life-saving or critical medical care, and the bad managed care companies would say, no, you can't have that really important care. And they would deny they would initially deny the patient their care. And then one of our heroic doctors or nurses would, fight for the patient. And eventually they'd make the managed care company pay for the critical care, and everyone would be happy in the end. So managed care came into being because we saw so much excess use and so much expenditure, right, on healthcare. So managed care came into being because our costs are wildly out of control, and they still are. But in the 90s, people hated managed care. Now, they liked the fact that managed care plans were cheaper than their indemnity plans, but they hated being told, no, you can't have that, right? And so it became a very popular theme, both in fictional media as well as in news media, to write all these awful stories about how managed care is doing terrible things to patients. And so there was this backlash against managed care, and a lot of initially. A number of the cost-saving controls that were put into place wound up getting lifted, and a lot of the cost savings just wound up not materializing. Now, most of us operate under some flavor of managed care today. Very, very few patients, somewhere in like 3 or 5% of patients, have what's known as typical indemnity insurance. And I'll talk about that in a second. Most of us are somewhere over here on the managed care continuum. So on this side, we have indemnity insurance. Over here, we have pure managed care. And what I've done is kind of placed a number of different programs and types of organizations on this continuum. And we'll talk about each of these here in a second. So on the far left side, we have Medicare, which is something like a managed care, something closer to indemnity insurance. We have PPOs, we have HMOs, and a whole bunch of different kinds of HMOs. Medicare A and B are closer to indemnity insurance. Medicare C is a Medicare managed care plan, and it typically looks something like an HMO, but there's all these different kinds of Medicare Part C plans. So I can't tell you exactly, because you'd have to look at the specific plan. But basically, on the left end of this continuum, you have the most patient freedom for picking their physician, picking their hospital, going directly to a specialist. If you have indemnity care, you could just go straight to an orthopedic surgeon if your knee hurts. It also has the least integration of the quad model we've been talking about. So the least integration of paying and insurance, right? On this end of the spectrum, as we move more towards managed care, more towards supply side controls, patients give up their choices. They submit to supply side controls. So a lot of different permissions and reviews by the managed care companies. It has the greatest integration of the quad model. And this is where the insurance companies really impose what we've been calling supply side cost controls, where they limit your access basically to prevent you from spending too much. So indemnity insurance is kind of classic insurance. It usually comes with a high deductible, right? So that's that high dollar value that you have to spend on healthcare before the insurance company starts to share it with you. And then typically higher coinsurance, so 30% coinsurance, something like that. Now, the beauty of indemnity insurance is there's no gatekeeping function to, pure indemnity insurance. There's no gatekeeping function. You don't have to have a primary care provider, and you don't have to go to your primary care provider and say, "Mother, may I?" Right? That's an old game. I don't know if you guys played that game when you were a kid. Sort of you play on your, you're out at recess and you're like, "Mother, may I take 2 steps forward?" "Yes, you may." And you can take 2 steps forward, yada, yada. So in this case, under managed care, you have to ask permission from your primary care provider or your primary care manager before you can go get seen by a specialist. So if your knee hurts, you can't just go directly to an orthopedic surgeon. You have to go see your nurse practitioner first. Then your nurse practitioner will make a plan, decide whether you really need to go see an orthopedic surgeon or not. Right? Typically, there are no network restrictions. So that means that if you decide you do need to see an orthopedic surgeon, you can go to see any orthopedic surgeon you feel like going to see. Right? And then the payment to the providers is based on a fee-for-service basis, which means every time they do something for you, you pay them something. So between you and the insurance company, you pay the providers every time you go to see them, right? And the and what's unique about indemnity is insurance, pure indemnity insurance. The old this is like the original Blue Cross medical insurance from the good old days. And so the insurance company doesn't negotiate with the providers. What they have instead is kind of a scale that says, this is the usual and customary price that we pay for an office visit. This is the usual and customary price that we pay for a knee scope. This is the usual and customary price we pay for whatever, particular procedure, visit, whatever that you're getting from your provider. And so there's very little engagement with the insurance company, either with the patient or with the provider. It basically is just a source of collecting and consolidating pools of cash and then paying bills. So under provider revenue under indemnity insurance is pretty straightforward, right? So down here in the x-axis, we have the number of visits. Up here, we have the total amount of revenue that providers get. And so as providers do more visits, they earn more revenue, right? So revenue increases with each additional visit that a provider does. So what's the incentive for a provider? Do more visits if you want to make more money so you can pay for that, third house out on Martha's Vineyard. So providers are under indemnity insurance and generally under fee-for-service are incentivized to do more visits so that they can make more money. Now, preferred provider organization is kind of somewhere in between an HMO and pure indemnity insurance. It still uses a deductible and coinsurance with the purpose of limiting your excessive use. They may or may not have a gatekeeping function. So you may or may not be required to have a PCM. It kind of depends. The PCM is not necessarily a critical part of the PPO arrangement, but these are contracts, and so they can kind of be written in a variety of different ways. So you could have a contract where you have to use a PCM to get permission to go to a specialist, or you may not have that contract. Typically, if you don't have to go to a PCM, before you access specialty care, your 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 premiums, sorry, a little bit of brain lock there. Your premiums will be higher. Why? Because the insurance company is going to assume the reason that you chose to have the plan without the PCM is because you're more likely to use specialty care inappropriately. And so as a result, they're going to prospectively charge you a higher rate, but you're basically paying for more freedom under a PPO that doesn't have a PCM requirement. Now, what is specific about the PPO versus indemnity is, and this is what characterizes the PPO, is they have a network of preferred providers, hence the name preferred provider organization, right? The insurance company, INCO, is what I'm abbreviating it. The INCO negotiates a contract with a panel of providers. So that's the network. And the providers who are in network agree to work for discounted rates. So if the typical doctor's visit was $100, the PPO says to the doctors, if you're in our network, we'll pay you $70 per visit instead of $100 per visit. But we will guarantee you that these 10,000 people will have your name and they will be calling you because we're going to funnel all these people to you. And so the benefit of being in network to the provider is they kind of have this captive audience, right, for their services. And so if you're a beneficiary, you're going to say, okay, if I go to Dr. A, it will cost me $70 because he's in network. But if I want to go to Dr. B, Dr. B is not in network, and that's going to cost me $100. So if you're Dr. A and you're in network, you're more likely to get all these patients coming to you because they want to get that discounted rate, right? So that's what's valuable to the physician, even though, or the provider, whether it's physician, hospital, physical therapist, right? So the PPO contracts with all kinds of different providers so that you have this robust network to pick from. Kind of a variation on the PPO is to have a narrow network. So how limited the network is, when you reduce the network, you're basically narrowing a funnel. So if you've got a lot of beneficiaries, you're an insurance company and you have a lot of beneficiaries and you narrow the funnel a lot, you're sending lots of beneficiaries to very few doctors. That's really valuable to those doctors. And so they are willing to charge or take even deeper discounts, right? So instead of, say, charging $70 per visit, they'll charge $60 per visit because you're going to send them so many of your beneficiaries, right? So a narrow network has a very small number of providers in the panel. If you're willing to have relatively little choice of which providers you go to, a narrow network PPO will typically be cheaper for you as a person looking to buy insurance. But again, all of these things are about reducing choice. So as you reduce your choice as a beneficiary, as your choice gets reduced, your prices also go down, right? So you're giving something up to get a lower price. So network restrictions is the other piece of this. So we're going to have a network, and then we're going to have these network restrictions. So open panel plans allow patients, is the option that I said before. The insurance company will pay $70 for Dr. A, who is in network, but they'll still pay for Dr. B, but it's going to cost you a higher co-share or co-payment or co-insurance rate, right? So it's going to cost you more. If you're an open panel, you can go out of network. It's just going to cost you more. Under closed panel plans, you can't go out of network. If you go out of network, you're on your own. You're not covered unless it's an emergency. You're not covered by the plan. So if you go, if you go in network, you get it's $70 for a visit. If you go out of network, it's all out of pocket. Whatever it costs, $200, $500, that's on you because you went out of network. So again, closed panel plans, they take away some of your choice, but they're typically cheaper, right? So again, you're sacrificing choice to conserve on cost for you as a beneficiary. This is essentially a fee-for-service plan, right? So the doctor gets a payment. That payment, though, is based on the network contract rate rather than the usual and customary rate that we talked about under indemnity insurance. So how do providers make their money under a PPO? Same thing. More visits, more money. The revenue increases with each of the visits, so the provider has the incentive to do more. It's just that they're probably making a little less money per visit. But again, the goal of a provider joining a PPO network is to get beneficiaries funneled to them, right, and keep them from being funneled to their competitors. Okay, so the third broad category is the HMO, right? So the HMO, Health Management Organization, is meant to be what it sounds like, right? It's more focused on wellness. It's more focused on the comprehensive health of the patients. And you'll see why in a second. So usually there's a lower deductible and lower coinsurance, and that's especially true for wellness visits. Now, the advent of the ACA has forced all insurance plans to cover a lot of wellness stuff at no additional cost to the beneficiary, to the patient. That doesn't mean it's free. It just means the insurance company is rolling all those costs into your premiums. But that's what an HMO does, right? And the HMO's goal is to keep you healthy. And you'll see why when we get down to payment, right? So the key thing about PPOs was the network, right? HMOs have networks, and they vary depending on the flavor of the kind of HMO. But crucial to the HMO is the relationship between the patient and the primary care provider or primary care manager. And I kind of flip back and forth between saying primary care provider or primary care manager. I think your book prefers PCP. I typically say PCM, even though I think I often say primary care provider, and then I say PCM. Same thing, just a different terminology for the same thing, right? Your PCM is your primary care provider, your primary care manager. That's going to be your family medicine doc, your internal medicine doc, your nurse practitioner, your PA, right? Your pediatrician if you've got kids. And so under an HMO, this is typically access to specialists is typically closely managed by the PCM. Right. And so the PCM provides a gatekeeping function. Before you can go see an orthopedic surgeon, you have to come to your PCM, and your PCM has to look at your bum knee and say, yep, that's a bum knee. You should go see an orthopedic surgeon. Right. And so even though you can be like, yeah, no kidding, I kind of knew that. This again is the cost of going to see of being part of an HMO is this gatekeeping function. Now, sometimes the PCM can look at your knee and say, yep, that's a bum knee. You know what? Instead of going directly to an orthopedic surgeon, why don't we send you to physical therapy? Because you know what? A lot of time, knee pain will work itself out with a little bit of exercise, a little bit of stretching, and a little bit of time, frankly. The human body is a pretty remarkable, resilient thing. And so before we send you over to, the orthopedic surgeon who, may decide, if they're an aggressive surgeon, might decide to give you surgery when maybe you don't really need it. And so typically what this kind of system does is it slows down the utilization of high cost services like an orthopedic surgeon. they insert before you get to the big guns, they send you to the little guns. The little guns being physical therapy, right? So physical therapy costs very much less than a knee scope does. But if we can get you through get you fixed up, right, and back to running without having to give you a knee scope, that's a good thing, right? So core to the HMO is the relationship between the patient and the primary care manager. Now, they also have network restrictions, just like the PPO. But the other key difference between the HMO and the PPO and the HMO and the indemnity insurance company insurance plan is capitated payment, right? So providers who are part of an HMO receive a fixed payment based on the number of members that they are agreeing to provide care to. So if I have a panel of patients, in this case, not providers, but so providers talk about, when they talk about how, the patients that they provide care to, a primary care provider will talk about a panel. And so that is the number of patients that that rely on them for primary care. Typical panel for a primary care provider, a primary care physician, is somewhere in the range of 2,000 patients. It's a lot of people to provide primary care to. But that's a pretty standard number. And so if you're a primary care provider providing care to 2,000 patients who are part of an HMO, right? If you're a part of an HMO, the patients, those 2,000 patients, are going to be paying a fee through their insurance company to you as the provider on a per member per month basis. So let's say that's $10 per month. So you'd have 2,000 patients paying $10 per month. So that's $20,000 per month times 12 months per year. So 20,000 times 12 is $240,000. So if you were a primary care provider, the patients would be paying you $240,000 a month in capitated payments. So how do providers get by on this? Well, unlike the indemnity insurance or the PPO, right? Their reimbursement, their revenues are not tied to visits. They are a fixed payment. So in the version I just gave you, $10 per month per member per month times 2,000 members times 12 months is $240,000. So the provider in this case would get $240,000, whether they did one visit or 10,000 visits, they would get $240,000, right? So revenue is based on the number of covered lives. That's the phrasing we use, covered lives, not volume. So as volume increases, I don't get more money. I get the same amount of money. So in this case, providers have an incentive to do less, right? They have an incentive to do less care. Now, if they do too much less, the patients will be like, this is not good care. I'm going to quit seeing you. So the incentive is to both do less, but also to incentivize focusing on wellness for your patients so that they don't need expensive care. So the HMO, Health Management Organization, right? HMO, is meant to incentivize and reward providers for taking good care of their patients, for making sure that they don't wind up having a heart attack, for making sure they don't have complications from diabetes, right? And so, so that's the difference here. Now, there's a bunch of different kinds of HMOs, and it really all depends on the relationship between the HMO, the insurance company, and the oh, my dog. Had to pause that because my dog was having a fit. Okay, so the difference in these models is really the relationship between the insurance company, which is the HMO, and the providers. So under a staff model, the HMO employs the staff, employs the physicians, right? And maybe owns the hospital. So this is the Kaiser Permanente model. Everything is inside. And so, And typically the physicians are on salary. So a Kaiser Permanente physician does not make more money for seeing more patients. What they make, they may make more money based on how healthy their patients are by, whether they came and did all their appropriate preventive medicine, whether they controlled any patients that had diabetes, things like that. Now, the group model is the HMO and the providers are separate entities, and the HMO contracts with a group. And so the group would be typically a multi-specialty physician group. So it'd be a group that would have primary care physicians like internists and family medicine docs that provide primary care, but then they would also have orthopedic surgeons. They would have cardiologists. They would have general surgeons. They would have, the kind of pretty much the full gamut of providers. And in this case, the HMO would write a check each month, a capitated payment, right, based on a per member per month fee to the group, and the group would be responsible for providing the covered patients, the covered beneficiaries, all the physician care that they need. And if the group can't provide that physician care, the group would be responsible for paying for buying the care from another physician or physicians group. So the group in this case is on the hook for the cost of any physician care that the patients need. The third variation is the network model. This is a looser version of the group model. In this case, the insurance company, the HMO, contracts with as many groups as they need. There might not, maybe there isn't a large multi-specialty group that would be able to provide that comprehensive care. And so they contract with multiple groups. Now, in this case, typically the coordinating person or group is going to be a primary care practice. So the primary care practice would receive this big check from the HMO, from the insurance company. And then the primary care practice would be responsible for managing the beneficiaries' access to specialists. And the primary care practice would pay the bills for every time one of their patients went to see a specialist. And so the incentive on the part of the primary care practice is to minimize how many bills they have to pay. So in this case, they'd be really incentivized to try to keep the patients in and seeing primary care instead of going to specialists, because every time they go to a specialist, they have to write a check, right? And then the last variation is the independent practice model, which functions kind of like a group model, except that the group in this case is a virtual organization that contracts with a network, right, of physicians and physician groups, and they all kind of come together. And so the IPA, the Independent Practice Association, is this virtual organization made up of a bunch of physicians that have contracted with the IPA. And so the IPA receives the big capitated payment and then pays the physicians out of it. Now, capitated payment is kind of the holy grail of health reform. Ultimately, we'd like to see all patients under a capitated model, but I showed you a couple of lectures ago, the reality is we're still mostly under a fee-for-service model with some value-based contracting mixed in. So some people are under capitation, but not most. One of the things that's happening now is this idea of value-based contracting. And one of the most common things we see is this kind of hybrid model, particularly with organizations that have PPO contracts. And so an insurance company would contract with a medical group. So for example, Wentworth Health Partners is the physician group at Wentworth Douglas. Core Physicians is the physician group associated with Exeter Hospital. So they would contract, they'd write their PPO contract with the physician group, and they would say, okay, based on where our beneficiaries get their primary care, and so this is the basis of the reliant status. Based on what we see, we have 5,000 patients, let's say, I'm just pulling a number out of the air, 5,000 patients that get their primary care from Wentworth Partners Healthcare, the Wentworth Douglas Physician Group. And the way we decide that they're reliant is because they get, say, 3 primary care visits a year from one of your primary care providers. And so we say they're reliant on you. And so those 5,000 people last year spent $5 million on healthcare, let's say, just making up a number. Last year, they spent $5 million on healthcare. What we're going to do is we're going to keep track this year of how much money those 5,000 people spent, those 5,000 people that we believe are reliant on you for healthcare. We're going to keep track of how much they spend. And we're going to reimburse you just, under our PPO contract, fee for service, just like we normally do. But at the end of the year, if those 5,000 people have spent less than $5 million on healthcare this year, we'll give you a bonus. That's called a shared savings contract, right? And so if the arrangement is, if they spend less, you get a bonus. But if they spend more than $5 million, we don't do anything to you. That's called an upside risk only or shared savings only model. Some contracts penalize the provider group. So if they spend less, so if they say they spent 4.5 million instead of 5 million, you'd get a bonus because you reduced their medical expenditures and you save money for the insurance company. So the insurance company shares those savings with you. And under an upside only contract, if instead the medical spend was $5.5 million, so the total expenditure went up, under an upside only risk, nothing would happen. You wouldn't get your bonus, but you would get your regular payments. Under a two-sided risk contract, if the medical spend went up, you would be penalized for not controlling the additional expenditures. So this is very popular. Most of the physician groups that I know in their contracts now have some shared savings or two-sided risk contracts as part of the contract. And this is becoming more and more dominant. So we're not really hitting the HMO, vision, which has been promoted for the last 40 years or so. Instead, what we're seeing is kind of this hybrid model that's helping us move along towards that goal of capitation. Now, another concept that came out of the ACA was this idea of accountable care organizations. These are basically shared savings, value-based contract. It's part of the value-based world, right? And so most of these are shared savings models and so they function very much like what I just described to you. The interesting thing is the accountable care organization can be an actual organization. So, for example, Dartmouth-Hitchcock is a large healthcare system. It's got a full range of services, right? It's Dartmouth-Hitchcock, largest hospital in New Hampshire, teaching hospital. It's got a full range of services. It's got multiple hospitals that are part of its network. It's got, I don't even know how many providers, but it's got lots of physicians as part of their system. And so they agree to take on responsibility, right, for reliant patients. Again, it's this definition of reliant is you're getting some amount of primary care from this organization, and they basically get paid for. They get bonuses if they save money, and they get penalized if they lose money. So now what's interesting about an ACO is you can be an integrated organization like Dartmouth Hitchcock or Leahy Health or MGB, Mass General Brigham, or you can be a virtual organization. So you can be some hospitals. So in southern New Hampshire, a group of hospitals got together and created an ACO. I think it's called Granite Health, and it's like 6 hospitals: Wentworth Douglas, Exeter, Catholic, right? I don't remember all the members. They're not in any sort of formal affiliation. They just agreed to work together to run this ACO. And then they collectively either gain, they benefit if there's a shared savings, and they lose if there's a loss. So ACOs have had mixed effect. We'll see, they're probably some part of the future, but it's hard to say. Now, I'm going to transition to talking about managed care to kind of mergers and acquisitions that have been happening, particularly with hospitals, but also with, you can assume, with physician practices and insurance companies are going through a similar process of consolidation. So this data I got to show you shows the number of hospital consolidations, so mergers and acquisitions of hospitals. So we know community hospitals, about 5,000 of them. So you can see each year, and it's an increasing number of hospitals are merging together to create systems. So whereas once upon a time, most hospitals were independent entities operating on their own, hospitals are becoming parts of larger and larger chains. So a lot of this has happened in New Hampshire. And here's one example. Elliott Hospital and Southern New Hampshire Medical Center got approved by the state attorney general's office to merge and form a new organization called Solution Health. Now, they haven't changed their names. The Elliott Hospital is still called Elliott. Southern New Hampshire Medical Center is still called Southern New Hampshire. But they've created this new entity called Solution Health. And both of those, both Elliott and Southern New Hampshire, are now owned by Solution Health. And so this is an example of a merger. A merger is when two organizations create a third organization, and then they both become owned by that third organization. Sorry, I meant to show you. No. I wanted to show you another variation was an acquisition. I guess I left that off. An acquisition is when the acquiring company purchases the acquired company, and the acquired company becomes part of the acquiring company, so that the acquired company ceases to exist as an independent entity. An example of that would be the Wentworth Douglas acquisition by Mass General. Mass General didn't create a third organization and then Mass General and Wentworth Douglas became part of it. Wentworth Douglas became part of Mass General, and Wentworth Douglas no longer exists as an independent entity. So here's some examples of mergers and acquisitions. So like I was saying, mergers and acquisitions have been happening like crazy across the country. They've been happening like crazy in New Hampshire. And here's just a sample of some that have happened in the last 6 years since I arrived here at UNH. So we have the North Country Healthcare is a combination of 3 critical access hospitals: Granite One, Catholic Medical Center, Huggins, and Monadnock. Huggins and Monadnock are critical access hospitals, so they kind of became part of Catholic Medical Center. Wentworth Douglas was acquired by Mass General. Solution Health, we just talked about. Frisbee was acquired by HCA. Granite One, this organization becomes merged with Dartmouth Hitchcock to form Dartmouth Hitchcock Granite One, a third entity. LRG Healthcare, most recently was acquired by Concord Hospital. So when hospitals go through mergers and acquisitions, they call them affiliations, but they're really mergers and acquisition or acquisitions. The problem with this is they also use the word affiliation to refer to alliances. So we just talked about a merger and acquisition. This is a formal merger or acquisition of two organizations. So there's two organizations initially, at the beginning of a merger and acquisition, and at the end there's one, right? So under a merger, there's a third organization created, and then the two original organizations become part of the third organization, and the two disappear. Under an acquisition, the acquired organization gets swallowed up by the acquiring organization. So in the beginning, there are two. At the end, there is one, right? An alliance is not a acquisition, but it's sometimes referred to as an affiliation. So Mass General has an affiliation with Exeter Hospital, and they have that affiliation for cancer care. So they have an arrangement where Mass General and Exeter collaborate and cooperate on providing cancer care to patients that are cared for by the Exeter Health Resources system. That's an example of an alliance. Mass General does not own Exeter Hospital. They just have a cooperative relationship where they have agreed to work on providing care. That's called an affiliation too. So this can be misleading when you hear that a hospital has an affiliation. It could be that they have gone through a merger or an acquisition, or it could be that they have an alliance. A different category of integration is a joint venture. In this case, two organizations might create a third organization, and that third organization might purchase equipment or provide a service that neither of the other organizations want to do on their own. So in this case, it's not a merger, right? We're creating this third organization. The other two organizations stay separate, and they just have shared ownership in the joint venture. So one example was Wentworth Douglas and Frisbee had I want to say it was an imaging center that was was a joint venture between Frisbee Hospital and Wentworth Douglas. And when Frisbee became part of HCA, Wentworth Douglas is a not-for-profit entity, and Frisbee joined HCA. HCA is a for-profit entity. So Mass General, who's now the parent of Wentworth Douglas, said, if Frisbee is going to be part of a for-profit entity, we can't continue to own, you can't continue this joint venture. And so they had to dissolve the joint venture. So before that, though, Wentworth Douglas was a part owner in the imaging center, and Frisbee was a part owner in the imaging center. I'm not sure it's an imaging center. It was something. It was an organization that they both had shared ownership in. So that's an example of a joint venture where they are, not coming together coming together to form one new organization, but they are forming a shared organization to provide a particular service. Some types of integration that drive some activities that drive integration are horizontal integration and vertical integration. So a horizontal integration is the merger of two similar organizations, right? And the goal is to achieve economies of scale. So the example I'm using here is Elliott and Southern. They're both, Elliott's quite a bit larger than Southern, but they're kind of similar peer organizations. And the benefit of them coming together is they can provide more care, but they can also achieve economies of scale. So for example, if you merge these two organizations together, you really only need one finance organization. So you really only need one chief financial officer. So you can fire one chief financial officer and keep the other one, right? You probably only need one CEO. You can have a chief operating officer for each place, but you can fire one of the CEOs, right? You can run most of HR out of one HR shop. Payroll can be run from one place. IT, this is a big one. We talked about how expensive information technology is. So IT can be run, from one organization. And importantly, you can have a contract with an electronic health record company that is very expensive to set up the contract, but not that expensive to add additional users. So those are examples of economies of scale where by being bigger, you can spread the cost of expensive assets over many people or a larger organization. Vertical integration is different from horizontal. So horizontal, think, going across. Vertical integration is up down. So a merger. This is an example of I'm using the phrase chain of value, right? So if you think about like maybe a car manufacturer, right? A car manufacturer, the end product is to produce a car, but Ford doesn't make tires, right? So one of the suppliers for Ford is, say, Michelin, because they make the tires for Ford. Well, if Ford bought Michelin so that they could integrate the tire manufacturing into Ford's overall process, that would be an example of a vertical integration because they're going backwards up the value chain, right? In healthcare, we have, say, primary care providers, we have community hospitals, and then we have, tertiary and quaternary care hospitals. So MGB acquiring Wentworth Douglas is an example of vertical integration. MGB gets referrals from Wentworth Douglas for their most complex patients. So Wentworth Douglas and MGB have this tight relationship. So if Wentworth Douglas gets a really sick patient, they can say, we're going to send you to Mass General. And then Wentworth Douglas gets access to MGB's specialists as well as the financial strength from MGB. And one of the cool things is, let's say they decide you need surgery, but you need it from an MGB, from a Mass General Brigham surgeon. We might do all your preoperative work at Wentworth Douglas. So we get your labs drawn, x-rays. You might even meet the surgeon at Wentworth Douglas. And then the day of the surgery, you drive down to Boston, you get your surgery. And when you get discharged, you come back up to New Hampshire where you live, and you get your follow-up care back at Wentworth Douglas again. So Wentworth Douglas keeps you in the system, right? And so, and MGB gets the part of the care that they really wanted, which was the actual surgery, not so much the pre and the post-op stuff. So that's the value of a vertical integration. And it's why you see big academic medical centers acquiring small hospitals, or larger community hospitals acquiring small hospitals. So like Catholic Medical Center acquired Monadnock and Huggins. These are tiny little critical access hospitals. And Catholic Medical Center is a fairly large community hospital. And so they, what Catholic Medical Center was able to do is kind of ensure that referrals would go to Catholic Medical Center by having that standing relationship with Huggins and Monadnock. Now, the last topic I want to talk about is antitrust. Now, all these mergers are good for the hospitals a lot of times, but maybe not so good for patients, because there's a fair amount of evidence that when hospitals merge, prices that patients have to pay go up. And so Exeter Hospital went through a multi-year process where they were trying to merge with Wentworth Douglas and then be part of the Mass General system. The Federal Trade Commission, which is the federal entity that looks at mergers and acquisitions to decide whether it's good for for consumers, in this case, patients as consumers or not. And then the state attorney general is responsible for doing that same kind of review. And both the FTC and the New Hampshire State Attorney General kind of pushed back on this idea, saying, Exeter and Wentworth, if you combine up together, that's too much concentration in the of care in this smaller market, and so we're not gonna let you do that, and so that fell apart not too long ago. So this is broadly called antitrust. What they try to do is avoid too much market concentration, because providers, if there's only one provider in town, they can charge a lot more money. And so that's called anti-competitive behavior. And I mentioned the FTC and the state attorney general get involved in those reviews. All right, so that is it for chapter 9. And we'll be back with chapter 10 shortly.